The first section in this video series is on fundamentals. Now, the reason that this is the first video and the reason that it's named fundamentals is because this is going to serve as a building block for every future section. And if you don't really understand the concepts discussed in this video, you're going to have a really tough time memorizing what you need to know for COMLEX and your in-class exams. So it's very important that you understand all of the concepts that will be presented in this first video. Let's just get right into it. There are 4 core tenets of osteopathic medicine. These are really the principles on which osteopathic medicine continues to thrive. Those 4 principles are that 1, the body is a unit. 2, the body is capable of self-healing and self-regulation. 3, structure and function are interrelated. And 4, rational treatment is based upon an understanding of these tenets. Now, when we talk about osteopathic medicine, what you'll hear often mentioned is somatic dysfunction. What is somatic dysfunction? Well, the formal definition is impaired musculoskeletal, myofascial, neurovascular, lymphatic, or arthrodial structures. And basically, that's just saying anytime there's something wrong with the body, regardless of what part of the body it is, you're likely to have somatic dysfunction. Somatic dysfunction is what osteopathic physicians treat when they do OMM or OMT. Now, the question that should be going off in your head is how are you going to identify that a patient, either in real life or a patient on your COMLEX / in-class exams, has somatic dysfunction? And the way that you'll do that is by identifying what's known as TART criteria. Now, let me pause for a moment because this is the first time you're seeing something in red on one of the slides. Anything that's shown in red text is very high yield, and it should be a reminder to you that it's a topic that you really need to understand and or memorize. So TART criteria is how we identify somatic dysfunction. What is TART criteria? The T stands for tissue texture changes, the A stands for asymmetry, the R stands for restricted range of motion, and the T stands for tenderness. So any one of these 4 components is going to be a clue that the patient, either again in real life or on the test, has somatic dysfunction. Now let's suppose that you're actually doing this in real life. You are going to go to the lab component of your OMM class, and you're going to have to do this in person. How would you figure out that somebody has these 4 TART criteria? To do that, you would perform an osteopathic structural examination. This is sort of like the physical that goes along with an OMM visit, which will allow you to diagnose somatic dysfunction. So what are the components of the osteopathic structural exam? The first part of it is that you look. You are just visually inspecting the patient. You're going to look for functional or postural dysfunctions. You can see things like if their head is too far forward, if they have imbalance between their scapula, etc. So the first part of the osteopathic structural exam is just visual inspection. So number 1, look. The next step is to touch. You need to palpate the patient's body in various areas, and you want to note things like the temperature or if there's any tonic differences from one side to the other. So step 1, look. Step 2, touch. Step 3, which sometimes is actually written as step 4, depending on who you ask, are special tests. For the purposes of COMLEX, you don't need to know a whole lot about these special tests, which include the skin drag test and the red reflex, but just know that these tests are used to determine whether or not somatic dysfunction is acute or chronic, and we'll get into more of this discussion in just a moment. The final step is motion testing. Motion testing is where you are going to actually assist the patient in moving various parts of their body to note their barriers. We'll talk about barriers more in depth in a few slides, but these barriers include the physiologic barrier, the restrictive barrier, and the anatomic barrier. But the big picture takeaway from this slide is that the osteopathic structural exam is the diagnostic component of an OMM visit, where the physician will look, then touch, then move the patient's body, noting all of those TART criteria to diagnose somatic dysfunction. Now, one of the big things that you need to know for COMLEX is whether somatic dysfunction is acute or chronic. And the way that you can differentiate whether it's acute or chronic is based on a whole slew of sub-criteria. Those criteria include tissue texture changes, tenderness, asymmetry, and range of motion, which again, all 4 of those are the TART criteria. And then there's also a couple other things like the skin drag test and vascular changes. So depending on how the somatic dysfunction is described in the question stem, the test writer could be telling you that it's an acute injury or it's a chronic injury. And not only is it important to know that distinction so that you can just get the question right, but it's also important because what type of treatment you would choose as your answer choice, either on the test or in person during your practical, that treatment would depend on whether it's an acute or chronic somatic dysfunction. So for tissue texture changes, acute somatic dysfunctions tend to feel hot, boggy, and edematous. But chronic somatic dysfunctions tend to feel cold, ropey, and fibrotic. As far as tenderness goes, acute somatic dysfunction will have sharp tenderness or sharp pain, but chronic somatic dysfunction will feel dull. For asymmetry, acute somatic dysfunction will be uncompensated, and chronic somatic dysfunction will be compensated. This should make a little bit of sense to you. Imagine that you are a baseball pitcher and you're throwing pitch after pitch after pitch and you hurt your shoulder. Initially, if you hurt your right shoulder, that shoulder might sag a little bit. You're not going to compensate for the asymmetry in the height between your right and left shoulder. But over the course of several years, if you have a chronic injury or chronic somatic dysfunction, your body will learn ways to compensate so that it can equalize your axial mechanics. As far as range of motion goes, in acute somatic dysfunction, the patient will experience pain with range of motion of the affected injury. And in chronic somatic dysfunction, the patient will not feel pain with range of motion of the affected injury. Again, this should make sense. If you have a recent injury causing acute somatic dysfunction, that's going to hurt. But over time, as the body gets used to it and the body compensates for it, that pain will be less likely. The skin drag test for acute somatic dysfunction will show increased drag. But for chronic somatic dysfunction, the skin drag test will show decreased drag. And lastly, vascular changes. In acute somatic dysfunction, you may note the presence of venous congestion, but in chronic somatic dysfunction, you'll note neovascularization. Again, this should make sense. Vascular changes acutely become very congested because there's an inflammatory process happening that the body was not used to. But over a long period of time, in chronic somatic dysfunction, new vascular networks are being created to compensate for the vascular insult. This entire chart, bordered in red, is incredibly high yield. Please memorize these differences between acute and chronic and know them well. Now we need to switch gears and talk about barriers and motion. Before we get into this conversation, we need to talk about the 2 basic types of motion that can occur either by the patient or the physician. Active motion is when the patient acts alone. If the patient moves something actively, they are moving that body part themselves. Passive motion is when the physician assists the patient in moving. So A, active, A, alone, P, passive, P, physician. You need to know this because in the question stem, or possibly even the answer choices, you'll have to understand the distinction between active versus passive motion. Now that you understand the types of motion, let's talk about barriers. There are 3 main types of barriers that you need to know for COMLEX and your in-class exams. The first is the physiologic barrier. The physiologic barrier is the range of motion that's achievable by the active motion of the patient. So again, active patient is acting alone. So the physiologic barrier is the range of motion that the patient can achieve in a certain body part or joint, etc., when they move by themselves. The anatomic barrier is the range of motion that's achievable by the passive motion of the patient. So in this case, the patient can move their arm by themselves to a certain degree, and then the physician giving passive motion, remember passive P, physician P, can move that joint or their arm, for example, a little bit more, and eventually you'll come up on the anatomic barrier. What's important to note about the anatomic barrier is that, as the name implies, this is limited by your anatomy. So you can only abduct your arm to a certain extent before, if you try to go beyond that point, you'll just break your arm or dislocate your shoulder. So your anatomy limits the range of motion that's achievable in every joint in the body. So what's important to take away when we talk about the anatomic barrier is that motion beyond the anatomic barrier results in tissue damage. The third and final barrier that you need to know is the restrictive barrier. And for the purposes of COMLEX and OMM in general, this is really the barrier that we care about. The restrictive barrier is the abnormal range of motion achievable by active motion of the patient. So basically, the restrictive barrier is a patient has a physiologic barrier, and then they get somatic dysfunction, and their physiologic barrier changes abnormally, and it usually gets reduced in some way, and now they have a restriction. So let's talk about these three barriers in an example just to really hammer home this point. Let's look at somebody who's performing shoulder abduction, ABduction. So normally, ABduction can go from 90 to 150 degrees. Of course, this will depend on how much you stretch and how much you work out, but in the normal person, the physiologic barrier should be between 90 and 150 degrees. So this is the physiologic barrier. The anatomic barrier would be moving beyond that 150 degrees. Imagine that this person tried to abduct their left arm even more than 150 degrees. And in doing so, they would really need somebody to kind of jam their arm more to their right, going beyond that 150 degrees. But if they do that, you're going to have tissue damage. They might dislocate their shoulder. They might break their arm. Who knows? This is something that you don't want to do because the anatomic barrier is the upper limit of the range of motion that's imposed and depends on your anatomy. So that's the anatomic barrier. And lastly, let's say that this person has an injury, and now instead of being able to abduct their arm from 90 to 150 degrees, they can only raise it this high. Obviously, the person has an injury, and that's why they can't lift their arm above this 70 degrees. But in this example, their restrictive barrier is 70 degrees. So again, these three barriers are very important to understand for COMLEX. Please understand the differences, and we're going to be paying special attention to the restrictive barrier moving forward. Now let's talk about a very important topic, naming somatic dysfunction. A lot of questions on COMLEX are likely going to test you on naming somatic dysfunction. It seems easy at first glance, but it can be tricky if you're not paying attention, so this is incredibly important to understand. As a general rule of thumb, somatic dysfunctions are named for their ease. The ease is the direction that a segment, like a vertebral segment, or a group of vertebrae, or any body part, prefers. So when you hear somatic dysfunction, and we'll talk about this more in just a second as we get into some examples, they're going to be named for their ease. They're going to be named for the direction that they prefer to move in. And the opposite direction of the ease is referred to as the bind. The bind is the direction that a segment or group does not prefer. So keep these ideas in your head moving forward as we learn about how to name somatic dysfunction. In order to name somatic dysfunction, you have to understand a couple rules, and these are known as Fryette's laws. Fryette's laws are a set of 3 laws that describe the rules for spinal motion. They only apply to the thoracic and lumbar spine. That's incredibly important to know. That's very high yield. They only apply to the thoracic and lumbar spine. What are the 3 laws? Law number 1 says that in a neutral group of segments, side bending and rotation occur in opposite directions. So law number 1 is a group of segments. They're neutral segments, meaning they're not flexed and they're not extended. And in this group of neutral segments, side bending and rotation occur in opposite directions. So let's look at an example. T3 to T6 are neutral, side bent right, rotated left. This is the shorthand that you will see on COMLEX and your in-class exams. This is how osteopathic physicians write out somatic dysfunction. In this example, the vertebral segments, a group of them from T3 to T6, are diagnosed as neutral, that's what the N is, side bent right, that's the SR, rotated left, that's the RL. This is how you write somatic dysfunctions. The first part is the group of the segments or the individual pair. The second part is neutral, flexed, or extended, so either N, F, or E. And then you do side bending, right or left, so S blank, and then rotated, right or left, R blank. This is how we're going to write somatic dysfunctions. But law number 1 will tell us that side bending and rotation occur in opposite directions in a group of neutral segments. Let's move on to law number 2. Law number 2 says that in a single pair of segments that are flexed or extended, side bending and rotation occur in the same direction. So let's do an example. T6, flexed, side bent left, rotated left. As you can see in this example, we're talking about T6. It's flexed, so it has to be flexed or extended for law number 2 to apply. And in this case, it's flexed, so you see the F. Side bent left, rotated left. Because this is a flexed single segment, side bending and rotation will occur in the same direction. And in this case, it's to the left. Law number 3 is a bit lower yield than the first 2 laws, but it's still important to know. Law number 3 says that motion in one plane decreases motion in other planes. And when osteopathic physicians or COMLEX or your in-class exams talk about planes, they're really talking about flexion, extension, side bending, and rotation. So as an example, extension will decrease the motion of side bending. So as a spine is extended, the amount that it can side bend will be decreased. This kind of makes sense if you just understand physics, but it's law number 3 of Fryette's laws. So now that you understand the 3 Fryette's laws, let's come back to this idea and this challenge really of naming somatic dysfunction. Let's do a couple examples to learn how we name somatic dysfunctions. Example. You palpate the transverse process of T6 and note that the right transverse process is more posterior. When the patient is put into a sphinx or an extended position, the asymmetry resolves. How would you name this somatic dysfunction? Well, in order to get this question right, you have to understand what a transverse process being posterior means. What does that mean? Imagine a vertebral segment with the 2 transverse processes kind of poking out on the sides. If the transverse process of this vertebrae is more posterior on the right, that means that this vertebrae is rotated right. And as you can see in my very crude 2D drawing here, right rotation means that the right transverse process is felt posteriorly. Or if you're palpating somebody's back who's lying prone, you'll feel that more superficially. The opposite would be their left transverse process, which because the vertebrae is rotated to the right, their left transverse process will be deeper or more anterior if you're palpating them while they're in a prone position. So because of that, now we need to figure out how we're naming this somatic dysfunction. So we know because we feel the right transverse process more posterior or more superficial that they're rotated right. We know that when we put them into a sphinx position, which is to say that we're making their spine extended, the asymmetry resolves. So anytime that asymmetry gets better in a certain position, it means that that vertebrae or that group of vertebrae prefer that position. So because the patient prefers to be extended, and because we name somatic dysfunction for the direction that a group of segments or a single pair of segments prefers, we know that this is extended. So far we know that this is extended and rotated right. And the final question here, which the vignette didn't really address for us, is what about side bending? Because again, all of these vertebral somatic dysfunctions need to be named with flexion, extension, or neutral, the direction of rotation, and the direction of side bending. So how do we figure this out? Well, recall Fryette's law number 2. If there is a single pair of segments that's flexed or extended, side bending and rotation have to occur in the same direction. So because we knew in this example that this was an extended single pair and it was rotated right, side bending must occur in the same direction. So side bending occurs to the right. Now we can write out the somatic dysfunction, and we would write it out as T6, extended, rotated right, side bent right. Done. Easy peasy. So you get this question correct by knowing Fryette's laws and inferring certain information from the clinical vignette. Let's move on and talk about the types of osteopathic treatments. Generally speaking, OMM can be categorized into either direct treatments or indirect treatments. Direct treatments are directed towards the barrier/bind. So direct treatments are directed towards the position that a part of the body, vertebral segment, vertebral group does not prefer. And as such, direct treatments are directed away from the ease or away from the direction that the body part does prefer. In an indirect treatment, that treatment gets directed towards the ease or away from the barrier/bind. So understand these two differences, because different treatments they can either be direct or indirect, and knowing that difference is going to be very important. Let's do an example. A patient is diagnosed as T2, extended, side bent left, rotated left. How would you initially position this patient if you were performing a direct technique? Well, in order to get this question right, I guess we need to know what the patient's ease is and what the patient's bind is, and then we'll figure out whether a direct technique goes towards the ease or towards the bind. So the patient is diagnosed as T2, extended, side bent left, rotated left. And if you recall, all somatic dysfunction is named for the ease or the direction that this vertebrae prefers. Therefore, the ease is extended, side bent left, rotated left. So what's the bind? Well, if the vertebrae prefers extension, side bent left, rotated left, then its bind is flexed, side bent right, rotated right. So it's just the opposite. Now, it's asking us, how would we position them if we were performing a direct technique? Direct techniques are directed towards the bind. So we would initially position them into flexion, side bent right, rotated right. That's going to be it for this first section. Again, these are the fundamental building blocks on which every other section in this course will be based. If you had any trouble with naming somatic dysfunctions, understanding different motions, understanding different barriers, etc., if you had trouble with any of that, rewatch this lecture, because we're going to build upon this moving forward.